Thank you very much, Parag, and thank you, ROC, for the opportunity. Now, my job is very simple because Parag has made it simple for me. If a shoulder surgeon can do an Oxford uni knee, anybody can do it. That's the first part about his difficulty in doing a uni knee arthroplasty. He's also conceded that if a patient is above 60, he himself will do a uni. That takes away almost 70% of your cases for a uni. So now I begin I'm not going to show any boxing rounds. I'm not going to crack any jokes. I'm going to give you sheer scientific data for you to make up your mind which one you will do when. So I love HTO. I love HTO. I've been doing HTO since 1989, and I still do it. Until you love something which is even better. What are the problems with HTO? Some of them have been enumerated in the last few talks. One is, and the biggest problem to me, is it's unpredictable. You do the same operation, the same technique 100 times, there will be a fair percentage of patients who are unhappy with the results, and we are not able to figure out why. There is a very obvious prolonged recovery period, which again Parag has himself conceded that it can take a long time for the tibia to heal. The relief of symptoms may not be complete. And lastly, you saw a paper by Anil Ranawat, you saw the paper by Roshan. If you look at those figures with proper perspective, it lasts in about 3/4 of the patients only for about 8 to 10 years. So there is a problem with longevity of HTO. And the biggest worry to me is this, that any operation which keeps changing too often, I'm worried. I'm worried about the results, about the predictability, about the reproducibility of that procedure. Here is an example. They came with closed wedge osteotomy, then they came with open wedge osteotomy, then they came with dome osteotomy, then they came with step osteotomy. I don't know how many of those osteotomies have come and gone, and they started with plastering them, as Anil said. His dad used to plaster, I used to plaster, my boss KV Chobal, KT Dholakia used to plaster, then came with staples, then they went back to plate, then they went back to plaster, and then they went back to plate with a different name called Pudu plate. So whenever these fixation techniques keep changing, it worries me. Now let's look at uni. First of all, let me confess, I'm not talking about fixed bearing uni. I'm only talking about mobile bearing. And look at this track record. A mobile bearing since last 30 plus years, the fundamental design remains unchanged. It's the same from day one. What has changed in phase 1, phase 2, phase 3, and now microplasty is only the instrumentation, a few changes in the sizes. But otherwise, the concept is unchanged. That gives me a lot of confidence. So what is this concept? If you have a spherical femoral component and a flat tibial base plate, and then you have an unconstrained, fully mobile polyethylene bearing, which is fully congruous, and I cannot think of any other uni implant which has a fully congruous mobile bearing poly. So therefore, with this concept, it is possible to have all the movements such as sliding, rolling. It is possible to have a large surface area of contact, and that generates essentially compressive forces and no shear forces, and all the surrounding tissues to be kept and restored to normal tension. And the credit goes to John Goodfellow and O'Connor, as you all know, since 1982. To me, a very simple logic is any operative procedure which replicates or tends to replicate anatomy has to be successful. So what is the anatomy? We all know what the role of meniscus is and how it helps a large surface area and avoids point contact. We all know how the meniscus is mobile in a normal knee. And this model of Oxford uni knee actually mimics anatomy. And if it mimics anatomy, see what happens. The wear rate is 0.03 per year, which means to wear off 1 millimeter, it will require 33 years. This is the plastic at 10 years retrieval. First done in 1982, so it's more than 30 years. In my books, the indications of full thickness cartilage loss of the medial compartment, an intact ACL and PCL, a functionally normal medial collateral, a correctable varus, and a near full range of movement. Now the results. Let's look at, Parag said that the results are not replicated. So let's look at this with proper perspective. So this is a 10-year designer series. 98% survival at 10 years. You may say that this is biased because it's by the designers. Then let's look at independent series. This is Sward and Price from Sweden, 94% survival rate at 15 years. Let's look at our own Rajshekhar paper along with Smith in 2004. We have 94% survival at 10 years. Let's look at Keyes from Macclesfield. You have 99% survival at 10 years. And if you summarize all these studies and you see for yourself that the results are somewhere in the late 90%. The bearing wear rate, as I said, is very, very, very minimal. It's 1 millimeters in 33 years. What about the polydislocation, the mobile bearing dislocation? With the newer modification in the poly, the current dislocation rate is 0.4% if you do the operation properly. What is my own personal experience? I'm going to share you a few important thoughts of phase 3 instrumentation and give you some tips which have actually been incorporated in the microplasty. So these are 70 patients done between 2007 and 2011, typical demographic, average age 60 plus. And what we did is we measured the alignment of the femoral and tibial component in 2 planes, in the anteroposterior plane and the medial lateral plane. And what we found is that there is a additive effect, which means if you have malaligned in more than 2 planes, you have effectively 4 angles. If more than 2 angles are abnormal, it has an additive effect and will impact the result, the outcome. And therefore, what we found was that you will have a 2 or more angle outlier in about 6% of cases. And one of the main components which you are likely to malalign is the femoral component, because in phase 3, the femoral jig was not linked to the intramedullary canal. And that has been incorporated in the microplasty. Now the femoral jig is linked to the intramedullary canal, so it's not by eyeballing, and therefore it helps place the femoral component even more accurately. In conclusion, my series, Oxford, is a successful operation, 97 patients satisfied. Implanting the femoral prosthesis is now more accurate because of this microplasty modification of the jig, and malposition in more than 2 planes may affect the results. So here's an example, almost full movement. She can sit cross-legged, she can squat. Another example, he is again sitting cross-legged, which our Indian patients want to do. In summary, the results of TKR following UKR. This is again one of Parag's point. There are enough published papers which say that the results of a TKR in a failed UKR are equal to a primary TKR. Therefore, effectively, when you do an Oxford uni-knee, the knee implant has a life of almost 30 years. So my take is, if you have a patient below 50, yes, of course I will do an HTO, because they are high demand patients. But that's a small percentage. A large bulk of medial compartment OA are above 60. So in those, of course, I will do an Oxford uni-knee, and there is a very small role of arthroscopy when you have some mechanical symptoms along with osteoarthritis. So to me, I think there is no debate. I admire and I love Parag. We complement each other. The HTO and the uni do not compete with each other, they complement each other. You just have to select the right patient. But I doubt if Parag will do an HTO on this lady, even if she is less than 60 years of age. But we can still do a uni. Thank you very much.